WHIVFM.org. We honor independent voices. We are not a radio station with a mission. No, we are a mission with a radio station, and that is to end all wars. Welcome to Resistance Radio. My name is Dr. Mark Allenderry. It is really an honor and pleasure today to be talking to Dr. Keith Ferdinand, who is the Gerald Berenson Endowed Chair in Preventive Cardiology. He's also a professor of medicine at the John Deming Department of Medicine at Tulane University School of Medicine. We will be talking today about his involvement with a great program called LA-CEAL, as well as talking COVID and vaccines. Dr. Ferdinand, it's a pleasure to have you on air with us today.
Thank you, Mark.
I guess when you're a colleague of mine, and certainly we work together at Tulane, and this is really the first time I've ever had a chance to sit down with you one-on-one. And I'm always fascinated with people's pathways and how they got to where they got to. So I would love to start this conversation, Dr. Ferdinand, by hearing a little bit about you and kind of how you got to where you got to.
Well, I've had a long, arduous path to where I am now. I'm a child of the lower Ninth Ward, born and raised, generations. I went to school, did well, went away to college, did well. And once I had some formal education under my belt, this would be in the 60s, I was trying to see what I could do with my education. And a bunch of us felt that it was important that we look at medicine because we started to see the statistics and we were aware that Black people were dying earlier and more often. Once I got in medicine, I further refined my focus to cardiovascular medicine, heart disease and strokes, chronic kidney disease, hypertension, diabetes, because the research was starting to grow about that time and I was becoming even increasingly aware that a lot of the death and disability, especially in the Black community, was caused by cardiovascular diseases. So it wasn't anything romantic. I wasn't a kid who had a toy stethoscope around my neck and always wanted to be a doctor. It was a cold-blooded decision to do something to impact the survival of my community.
And over that and the 60s is that's incredible that you've been in medicine for and have had a career like that. How was that decision for you, both as a physician and as a cardiologist?
Well, it takes time, it takes effort. You have high school, college, medical school, postgraduate, then specialization. Fortunately, I was not afraid of standardized tests. I had been taught by the old public school teachers in the segregated South when I went to elementary school. There were Black schools, white schools. But I was taught that I was as good as anyone else, that I would be able to succeed in whatever I wanted to. So if I had anyone who doubted me because of my background or because of my skin color, it didn't cause me any concern. It was like Jay-Z, I just dusted off and kept rolling. I think in general, when you look at medicine is now just waking up to these disparities, the increased death and disability that you see in certain populations related to socioeconomic status, geography, zip code, sex, gender, and geography. But they've been around for decades. And as a young kid, as I started to matriculate through college and get into medical school, I was aware of those disparities. But right now, it's the hot topic. I think every few decades or so, America feels the need to wash its soul clean, or at least the superficial trappings of guilt. But those problems that I'm talking about are long-term, long-standing. And in fact, if you know the history of New Orleans, most people really don't know the history of New Orleans. They think they do. What you saw in Katrina was actually seen previously in Hurricane Betsy, 1965. And you see people on the roof in Katrina stranded by the government. I lived through that as a kid. We were on the roof for 2 to 3 days, no food, no water, nobody coming to save us, bodies floating around us. So a lot of things that we think are new are not. Unfortunately, some of that energy dissipates with time. And I am not as hopeful as I was at once that America would ever change in a positive, meaningful manner.
Yeah, I mean, certainly with what we're seeing right now, with the massive spate of anti-voting and laws that we're seeing right now, I 100% agree with you. And it is somewhat difficult, and I'm glad that you are talking about this. Usually, these are topics of conversations that I love having because I think they're incredibly important to have. And I actually am 5 chapters into a book that I am starting to write, looking at the history of discrimination in medicine, because I agree with you that medicine itself, laughably, we had the editors of the Journal of the American Medical Association, the associate editor, who claimed that there was no racism in medicine, who immediately was fired. And then I don't know if you heard, the editor actually resigned this week as well for making comments that were as foolish as that. And I was one of those kids that was growing up that was interested in infectious diseases at a very young age. I think I read my first book on influenza at 14 years old, and that really set me forward. My father also was an optometrist in Los Angeles, and he was dealing with a lot of HIV in the 80s, and so he really put HIV in my radar. And I often say never, because you never know when you're gonna wake up in the mirror and look at yourself and see your father. Because I said I was never going to do HIV, which has now become my main specialty. But somewhere when I got into college and started to learn about what happened in Tuskegee, it has been a thorn in my side, and trying to understand how it is that you have a group of what was effectively infectious diseases doctors. They were public health practitioners. There was no infectious diseases at the time, but how it was that you could have these folks, these guys, these gentlemen, withhold treatment for a disease process that had a definitive cure about 11 years or so after the start of the trial. And it's been something that's been sitting with me for 30 years or 40 years, trying to understand how it is we got to that point. And I'm now starting to write this book. As I said, I'm about 5 chapters in. And what is in writing the book and in doing the research and studying, what is very clear is that and these are hard truths and these are hard to talk about, but that in those days, and I think a little less now, but it was beyond systemic racism. It was a 2-tiered or 3-tiered system that existed, in which communities of color, minorities, Black people particularly, were seen as an underclass, and that's the starting point of my book. And trying to figure out ways of undoing that damage I think is critical for the medical profession to move forward. My colleague Doc Griggs talks about the fact that it's the likelihood of a Black male physician going into medicine is the same likelihood as a Black male becoming an NBA player. I mean, those odds are very, very, very slim. And I think that the medical field itself needs to engage in what I call medical reparations, in which there needs to be not a superficial kind of the guilt of the past sort of thing. There needs to be a very, very hard look. As physicians, we need to do a very, very hard look at our past, what we've done in the past, and then what commitments we're going to make moving forward, so that we never forget and we never repeat the things that we've done in the past. So those are my thoughts there.
I heard you.
Thank you for sharing. I appreciate that. And your story is incredibly inspirational, and I would love to at some point in the future just have you come on just to talk about your further experiences as well, because I am certain that we would have a lot to talk about. But we're here to talk about COVID, and we're here to talk about vaccination rates. And so I guess a great jumping off point right now, because I know that you and I've attended some of the same meetings that you've been, and I've heard you talk about some of these things. But I know that in the beginning, when we were starting to look at vaccines, there was an initial consideration that the Black community in particular, communities of color, but Black communities in particular, again, because of the long shadow that Tuskegee brings, were thought to be the communities that were going to be experiencing vaccine hesitancy the most. And I think that was like, I don't know if it was just we all kind of, if it was just all group think, or if it was just drilled into our brains or whatever, but that actually is not really what we saw. So I was just wondering if you could comment a bit about, what actually happened with the rollout of the vaccine, and were you surprised about the uptake in communities, particularly communities of color, with respect to the vaccine?
Well, I'm on the governor's task force. I'm also on the Louisiana Vaccination Action Committee and the LA-CEAL, the Community Engagement Alliance from the National Institutes of Health. And we did have some reluctance in the Black community to utilize the vaccines that were approved by emergency authorization. Pfizer was first mid-December, Moderna followed shortly thereafter. But the hesitancy wasn't born out of ignorance. It was born out of some of the same issues that we addressed in our opening discussion, that the relationship between the Black community and medicine has been one that's a difficult relationship. While African Americans have higher rates of multiple conditions. I mentioned cardiovascular disease, heart disease, and stroke. That's the area where I specialize, but you probably can list a litany of infectious disease-related outcomes which are disparate. So that is why some of the slow uptake in the Black community was experienced. Kaiser did a review based on self-identified race, ethnicity, and it was less uptake early on. The other thing that came into play was the fact that there was some degree of mistrust of the government. At that time, the president was using, not President Biden, it was the other guy, was using the term warp speed, which I guess he found to be entertaining. But to the Black community, it sounds like they were rushing, moving too fast, had the safety guards taken down. So that there was a lot of lack of distrust in general with medicine. Then you lump into it the distrust with that present administration back in late 2020. Those combination of factors came into play. Now, what I saw later was a very vigorous uptake in certain Black communities, especially the older adults, people over 65. They don't want to die. And they recognize that the vaccine was helpful. Plus, because of the high burden of hospitalization and death, most Black Americans know somebody who is either related to them, or a neighbor, or a church member, or a social and pleasure club member who died. It slowed down somewhat, and the national statistics presently still suggest there's a lag of vaccine uptake in the Black community. So the reason I'm doing what I'm doing is similar to the decision to become a physician and similar to the decision to become a cardiologist. I've decided that because I have a long history of working in this community, a lot of people know me, that I would become a trusted messenger, and I would do the best I could to honestly interpret the data for my community.
And do you feel like that's been successful?
Well, I touch a lot of people. I talk to all of my patients, and before I ask them about their blood pressure and their medicines and chest pain and shortness of breath, I say, "You got your shot yet?" That's my first step. And then sometimes I'll kind of make it a joke if they haven't. But I'll hear people out. It's an individual decision. It's a choice. You can't make people get vaccination, and you really shouldn't. But I think most people, once you talk to them, you talk about some of the myths and concerns, and because it's coming from a trusted messenger, they get it. Yeah, I think I'm making a difference. I don't know, maybe not, but I think I am.
I'm sure you are. I mean, just having you out in the community. And again, I really do believe it's a trusted voice that is the most important, which is, again, why I think one of the reasons why we created those animations was to try to circulate those animations that I had showed you a moment ago off air, about the importance of getting vaccinated and showing people. And that one of the things that I felt like, the initial question I was going to ask you is, what mechanism do you use to help take vaccine hesitancy individuals from being vaccine hesitant to actually getting the shot? And my method is one of two. It's one is being a trusted voice, much like yours. But then two, I think by describing how the vaccine works, I think is so incredibly important. And then also, lastly, describing who actually was behind the vaccine, I think is incredibly important as well. And talking about Dr. Kizzmekia Corbett and her genius, really, to walk into the NIH at 29 years old, to get her lab at 29 as being a prodigy of immunology. And it just so happens that she started working on mRNA vaccines immediately and started working on COVID because of that spike protein. It was just the most obvious low-hanging fruit. There was no COVID-19. It was just such an obvious antigen that was such an easy something to build against. And so she was really, like all great science, right person, right place, right time. And so when I talk about that story, and especially if I'm talking amongst vaccine, those that are vaccine hesitant, not due to politics, because that's what we're seeing right now. Is we're seeing it's typically white people who lean conservative or are conservative are those that are the most vaccine hesitant. But when I'm not talking to those communities, when I'm talking to my patients, those people with HIV, those people that draw from communities of color or draw from the LGBT community that may be vaccine hesitant, when I tell that story, one, again, coming from a trusted voice, explaining how mRNA works, and then talking about Dr. Corbett, and then showing pictures of her and Dr. Fauci together, because everybody's seen Dr. Fauci. Unfortunately, Dr. Corbett has not really quite been out there. In fact, one of the next animations we want to make is an animation with Dr. Corbett, where Doc Griggs and I are showing what Dr. Corbett has done. So that's the strategy that I use, and just kind of wondering if that has been something that you thought would work, and then also your thoughts on Dr. Corbett and other people of color that were also really essential for getting these vaccines out to us.
Well, I think talking about the mechanism and using cartoons and simple examples may be beneficial. I usually don't have to go that deep into it in order to get people to feel more comfortable. I simply say that it's not a live vaccine. There's no coronavirus. You can't get coronavirus from it. There's no chip. It doesn't cause sterility. The mRNA is just a bunch of chemicals that the body digests and goes away in a few days. So I had Pfizer myself, which is very similar to Moderna, the one that partnered with NIH. What I tell my patients, you can draw my blood, you can check me. There's nothing there. The spike protein is basically in the body. The body makes an immune response, so when a real coronavirus comes, it'll say, hey, I saw that before, and it kills it. And that's about as far as I need to go. And then I'll just let people ask questions. As you know, most physicians, unfortunately, will come in the room. If they're a cardiologist, they'll look at the EKG, do a quick heart exam, then mumble something in Latin and walk out. And when you query the patient is what the doctor said, many times they'll say, I don't know. I don't do that. I sit down, I talk to people at culturally appropriate, literacy appropriate level. So I think I can touch people that manner. And when we do media work like this, I just, I be myself. I have all the professional degrees. I have fellowships, American Heart Association, American College of Cardiology, National Lipid Association, Association of Preventive Cardiology. I've been chair of multiple national organizations. I don't come like that. I come Keith from the ninth ward, just talking to people.
Well, I'm sure that must be incredibly effective. There's no question about that. And do you share any of the stories about Dr. Corbett at all, or do you talk a bit about?
I mention it, but you got to remember now. Again, I'm from the neighborhood. I'm a neighborhood guy, so I don't have to pull somebody down from Baltimore or Bethesda to make like, yeah, and they got somebody in Bethesda who look like me. No, I look like me. I'm here.
Fair enough.
I will bring her in if they start to, if there's a barrier considering that it's something that the white man is trying to push on us. Because Kizzy is from North Carolina. She went to schools with black people. She was educated at the University of Maryland, Baltimore, not the big one, in Langley. And she actually is a regular person. You're right. Maybe her story should be out there more. The other side of the story, Pfizer, which is the other mRNA vaccine, was developed by a company called BioNTech. So it's actually Pfizer-BioNTech. Pfizer is the American company that had all the money. BioNTech had the novel platform also with the mRNA. And the two scientists who developed the mRNA for Pfizer were Turkish immigrants. They happen to live in Germany. I've been to Germany several times. And the Turks in Germany are treated as third-class citizens. You'll see them on the street begging, et cetera. And a lot of the right-wing parties say there's too much immigration coming in from Central Asia and the Middle East. But those are the two scientists who developed the Moderna. So you got Kizzy at NIH, and then you have Turkish immigrants with BioNTech. So this idea that, you know, this is the white man came up with something and throwing us at us is not only oversimplistic, it's wrong. It's not true. It doesn't even reflect some of the lead scientists who made that platform. So I go all the way there. I go all the way to Germany and pull out BioNTech.
No, that's great. So I guess, you know, I always had thought that Pfizer and maybe I'm just splitting hairs here, but that Dr. Corbet did develop the vaccine, and then that was then I am blanking on the right word. It was licensed to Moderna, and then also licensed to Pfizer and BioNTech. So that
the BioNTech had the platform also. The platform was being developed at the same time.
Got it. Okay.
One in the United States at NIH, and the other with BioNTech. They were separate efforts. BioNTech didn't receive any so-called warp speed money.
Right.
There was no federal financing for that. It was independent. Right. And that's why Pfizer came out first.
Right. So one is I love Moderna's name because it has M and then RNA in it, and then right. I just noticed the other day that they actually trade on the stock exchange as mRNA, which I think is great. And so so I wanted to ask a bit about how do you talk about side effects when people do ask you about side effects of the vaccine?
Sure. Well, the term side effect is a little bit misleading because what I tell them is the body is making an immune response. Most people have heard of an immune response. The body is seeing those spike proteins, so it say, hey, man, look at these spike proteins. I'm going to fight the power. And some people will get a low-grade fever. Some people have even had a rash. Most people get a little tired, a little achy. But that's what's supposed to happen. Your body is supposed to see it and know it. And in fact, most vaccinations will give a little discomfort. Shinglets, which is for the shingles, and it uses particle proteins, actually has a more florid response than the mRNA vaccines. Older people tend to get lesser response. The second shot tends to be a little bit worse than the first. But it ain't like, oh my God, look at these terrible, terrible side effects. No, it's, oh yeah, the body sees the spike proteins and it's revving up the immune response. When I explain it like that, people got it. They're okay.
Absolutely.
I don't have to go into much more detail than that.
When, you know, Doc Griggs and I got both of our vaccines live on TV on Fox 8 together, and so I got particularly I was affected with a pretty good fatigue after the first dose. I was actually on the sofa for 2 days afterwards, forcing myself to get up and walk around the block or this sort of stuff. I was really tired. I'm usually very energetic. Thankfully, after the second dose, I didn't get anything, fortunately. Doc Griggs, on the other hand, was, and he's talked about this openly. We've talked about it regularly on our radio program. He was really, really, really quite ill after both vaccines. And so since then, it turns out with a really interesting article that was published that shows that people who had COVID previously had more severe adverse effects. And what I tell people is that because 60% or so of people are asymptomatic, they didn't even know that they would have had COVID, that if they are the ones that have these very, very a little bit more extreme adverse effects than somebody like myself who had very mild adverse effect. One explanation for it could be that you may have had an asymptomatic COVID. But
that's possible. But it's still in the same ballpark that I was talking about. Because if you've had COVID, you already have had an immune response. And then if you inject and get spike protein, the body says, aha, here it comes again. Didn't we tell them last time, don't be coming in like that? And so now the body makes even a more fluid immune response. So that's expected. The benefit is when you look at antibody levels and T-cell cultures, the people who've had COVID and then got vaccine are probably going to be protected for years and years, whereas those of us who just had the vaccine without having COVID probably even have less protection. So it all fits. I mean, it all makes sense.
So there was a great article that came out probably I'd say June or July in which of last year of 2020, where they went out and they looked at people with SARS-CoV-1, and they looked at memory B cells for SARS-CoV-1. 19 years later, they still have it.
Yeah,
they still have memory.
I'm aware of that.
Yeah, so I'm hopeful that moving forward, that those that are vaccinated and even those that have natural immunity, that this will be something that we will have moving forward. And although one of the questions that I get asked regularly from journalists is are we going to reach herd immunity? My answer to that is probably not. It's unlikely. Hopefully we do reach the 70% people at least getting one dose of a vaccine before July or on July 4th, as President Biden had suggested. But one thing that I do think is going to happen is that we will probably see COVID-19 and its associated variants that now fortunately have these designation of a Greek alphabet. We'll be living with them much like we see kind of influenza. It'll be a little bit, even though it'll be circulating, it'll be far less of far less severe in terms of virulence, and it'll take being hospitalized to having a cold, and ideally, because we already are vaccinated for it, that hopefully moving forward we'll be able to be covered with any future COVID viruses that we see in the future.
I'm aware of those data, but we have to be humble. There's a lot we don't know.
Absolutely,
and your audience should Google Manaus, Brazil, Manaus. It's a city of 2 million people in the Amazon. They had a horrible COVID outbreak in April, May of 2020. Those who don't know Manaus, Brazil, I'll give you, unfortunately, a very vivid picture, which may be disturbing to you. That was the place where they showed open trenches with bulldozers just pushing bodies in. And you kind of remember it because it was horrible. That was in the spring of 2020. They did some surveys, and they felt that the penetration of the virus was as much as 70%, which is just as good as what President Biden wants to do for the United States. Well, the unfortunate story, and I'm not trying to blunt your enthusiasm that we're going to have this thing and keep our foot on it. The unfortunate story is January, February, Manaus, Brazil was back to square one. So even having that horrible natural outbreak did not protect the people.
No, you're of course 100% correct, and we're seeing that in the Seychelles right now. We don't know if it's because they got the. What's so funny?
Huh?
What's so funny?
The Seychelles, we don't know, but it's one of the most heavily vaccinated societies in the world. It's a series of islands off the coast of Africa.
Right,
but the vaccine they got,
we're seeing the cases, and so I use Manu, Brazil, and Seychelles, when and you're right, I was being optimistic. So
It's all right, man.
No,
you have to feel good about yourself. It's
no. To be fair, Dr. Ferdinand, 2 or 3 weeks ago, I was leaning a little bit more on your side, and then now you've seen me lean a little bit on the other side. Yeah. So to be 100% fair, I 100% agree with you, of course. Now, I always talk about Manu, and then I always talk about the Seychelles. Of course, Seychelles is new, so this is something new that I'm talking about. But yes, that P1 variant ripped right through Manu, Brazil. And we're seeing right now, if you look at maps, South America is one of the most, as a continent, is highly vaccinated. They have extremely high rates of vaccinations. But right now, Uruguay, Argentina, Chile, Peru have some of the highest rates of cases right now. In fact, I think right now Argentina is hotspot number 1 in the world. And it's largely because of either P1 or P2. Now, apparently, if you read the data, now of course it's science, so it flip-flops. Every article's a little different, and and when I do this, I'm constantly like, I'm leaning, and that's where I'm leaning on that side of optimism, which you totally called me out on, because I do feel that at least the mRNA vaccines. I'm not going to speak about the Johnson & Johnson, and I'm going to ask you about Johnson & Johnson in a moment, but not talking about the Chinese-made or the Sputnik or AstraZeneca. But the mRNA vaccines do appear to actually provide, at least for the variants that we see now, alpha, beta, delta, and gamma, the ones that we see right now, they do appear to the variants do not evade the vaccines.
Let's not lose the audience. They're moving over to Z to listen to some music at this point. I think that what you're saying is that perhaps the Pfizer and the Moderna are much more effective, even with the variants that we have now, than what we see with some of the vaccination efforts in South America, which are failing. Okay, that's fair.
Okay. But listen, I do want to go back to the point that you're making. We don't know where new variants may come. One of the questions, especially in early of 2020, that I would get was, what do you fear the most? And I often say I fear COVID 2022. And what I did not expect, it was long before the talk of variants, and I didn't realize that we would have COVID 2021 in the form of 4 variants. I did not expect that at all. And so, but I am concerned, and we don't know yet. One of the things that I'm doing with, I'm sure you are familiar with Dr. Trivia Frazier, who is really one of the most talented people that I know. Dr. Frazier and I are starting a variants lab here in New Orleans. It's called NOLA Variants, and I'll, for listeners, I'll give you guys more information about that as we get along. But what we want to give to Mayor Cantrell is the ability for her to be able to have at her fingertips at all times an idea of what the variants are that we have here in Orleans Parish, where it's really going to be Region 1. So it'll encompass all of what Louisiana Department of Health refers to as Region 1. And so there'll be a dashboard that you will always be able to refer to, so that we will see what is happening. So if we do see an uptick of a variant that is of great concern, ideally it would help the mayor make decisions that may.
All right, so can I take the step to try to crystallize what I think all of this means for the public?
Yes.
We all should embrace vaccination. It's the only way we're going to get out of this pandemic. The mRNA vaccines are very effective. We're doing a grand experiment now with everybody going out, no mask, only 40% vaccinated, that the mRNAs will be enough to hold us back. If we do get some variants that come into our society that the mRNAs are less effective, we could have another spike, and it may actually be even worse, because now you have people who are relatively healthy who are going to be affected even more, since most of the older persons, about 75, 80% people over 65 have gotten vaccinated. You're going to have young people who get sick and hospitalized, and you're going to have some unnecessary deaths. So I think the way to get out of the pandemic is to embrace the vaccination and have at least some degree of mitigation. You don't have to wear a mask when you're jogging, playing tennis. You don't have to have a mask when you're just walking down the street. If you're with family and friends and you know they've been vaccinated, there's no need to mask. But if you're going into a crowded settings, a small New Orleans hole-in-the-wall ball, and you don't know who's next to you, you probably should wear a mask.
Yeah, I 100% agree. I'm still masking. In my clinics, everybody's masked, obviously, in the healthcare setting. I actually was at Tulane Medical Center yesterday to see my doctor, and of course, we were all masked, and I appreciated that. And even in my clinics, I see patients and I have them double mask. Just like, I don't know why, but I just feels still right for me to do right now. And but I agree, vaccinations are really the only way that we're going to get out of this. Any thoughts about the likelihood of us needing booster shots and the fact that mRNA vaccines, or mRNA technology rather, will allow us to get to creating boosters more rapidly, and then also the idea of mRNA technology being utilized for other disease processes like HIV or other infectious diseases? I read a really wonderful article this morning that I made a video about mRNA technology being utilized for treatment of cancers, and actually predicting what the mutations are for cancer cells, and then building a personalized mRNA treatment based on those mutations as well. And then lastly, any idea of how mRNA technology could affect your field in cardiovascular disease?
Okay. Well, let me go backwards. I'll go cardiovascular disease, then I'll talk about the boosters.
Okay.
In cardiovascular disease, we already are taking manipulations using antisense oligonucleotides and silencing mRNAs, where you can turn off things. We're not able to make healthy genes that somehow the person has better blood vessels or better heart, but we're able to turn off some things like amyloid, which is a type of starch-like substance that comes out of the liver, and it goes to the carpal tunnel in the eyes, and it goes to the heart and damages the heart. They now have means of turning off the pathway that makes that. So it's like Moderna in reverse. Versus making a protein, they're able to turn off the synthesis of one. So that's right now, right here. The clinical trials are ongoing. The outcomes, meaning that it shows whether or not people live longer, have not been proven, but it's already being entertained. They're even looking at ways of affecting cholesterol metabolism using that pathway. So yeah, in cardiovascular medicine, yes. Cancer, I don't know as much about some of the emerging therapies in cancer, but there's no reason for me to believe that if there is a protein that accelerates the cancer process, if you can silence it through interpreting the code and then switching the code and giving an antisense oligonucleotide to the code, that you won't be able to turn off that signal. But I don't know cancer that well. In terms of the general population, what do I think? The antibody levels with the mRNA vaccines, Pfizer and Moderna, are very, very high. They seem to be very protective. I would think that the variants that we have now, as you say, they've changed it from the one from UK, one from South America, one from Brazil. Now they're going alpha, beta, gamma. They're going to run out of Greek alphabets.
No question about it.
So I don't know why they started that.
It's like naming storms. Like they're going to run right through all the...
Yeah, we're going to run through that. But I think the mRNAs are going to be successful. And if we can keep the number down in the United States of the variants, then maybe we won't have to have a booster, because I think the antibody levels are very, very, very high. But I'm okay with the booster. I mean, I'll take another booster if I have to. Yeah. HIV, you know much more about that than I do. But I think in terms of the pandemic, I'm a ponderer. I'm a person who gets an idea and mulls it over for days and days and days. And I had already gotten interested in what was happening with the coronavirus. In fact, I was looking at it on a daily basis before it became a pandemic. And I could not figure out how we're going to get out of this doggone thing. So when the successful vaccines came into play, I was more than helpful or more than happy to become a trusted messenger, because I had already gone through the process that there's no way we're going to get out of it. Where you let the virus just kind of rip through the community. The former leader of the United States talked about that, and the president of Brazil has used that method. All it does, it leads to immense death and disability. The virus is looking for a host, older people, immunocompromised, diabetes, obesity, chronic kidney disease, sickle cell disease, HIV, AIDS are going to just die. So the vaccines were very, very important. We've already had over 600,000 people who died. And it would have been much more if we didn't have the vaccines.
I obviously 100% agree with everything that you're saying. I was wondering if we could slightly shift the conversation a bit to your field and look at COVID and the heart. And two questions is there's a lot of talk about myocarditis and the vaccine. And if you could help us understand what is happening there and that it's actually the virus, but then also, can you talk to us about one field of medicine that I'm really interested in is looking at what happens with people with COVID, but then 5 to 7, 10 years, 20 years down the line, like could there be, we are seeing evidence of pulmonary scarring, there's scarring in the parenchyma, and we have seen that people who had myocarditis as a result of COVID in the past, are there, especially with athletes, are there long-term adverse effects as well?
So let me address, first of all, the concern that, and it's mainly with Pfizer thus far, that somehow it causes myocarditis. It's really hard for people to wrap their head around causality versus association. Causality means you do something and it causes something. Association means you do something and something else happens, but it didn't cause it. The episodes of myocarditis that were seen after people were vaccinated were mainly young men. They didn't have anybody who had died or anything serious. They got chest pain and had some markers of inflammation in the heart. So the CDC is investigating whether there's a relationship between the mRNA vaccine and the inflammation of the heart. Myo means muscle, cardio means heart, itis is inflammation. But that association is not necessarily causality, because every year young men get inflammation in the heart, myocarditis, from a wide range of viruses, as you know. And it tends to peak in the springtime, which is where we're at. And COVID-19 itself can cause inflammation. You've already suggested that a lot of people who had COVID didn't know it. And if you do get COVID-19 and it's a more severe form of COVID-19, the risk of myocarditis inflammation is like 10, 15, 20 times more than this association that we've seen in some isolated cases after the mRNA vaccine. So the news likes the story. It sounds really terrifying, CDC investigating whether or not mRNA vaccines cause myocarditis. Oh, Lord, I don't want to get that. So you get COVID, you can get myocarditis. The long haulers are what the NIH calls the post-acute SARS-CoV-2 syndrome. SARS-CoV-2 is the fancy name for the coronavirus. Post means afterwards. In large surveys now has been seen anywhere from 14 to 30% of people. And there's publicly available cases. One of them is a guy who used to play basketball for the Pelicans, Drew Holiday. He was out for a long time from a walk-in, and everybody thought he had like torn a meniscus or something. He had a really bad case of COVID. The other is Jason Tatum, who was the scorer for the Boston Celtics. And he's publicly said he gets tired and he uses an inhaler now. I have personally ordered chest x-rays in people who are still short of breath when I see them after they were admitted with COVID months ago, and it will show patchy areas of interstitial scarring. So this idea that I don't want to get the vaccine because I might get myocarditis, or I don't want to get the vaccine because I might get a blood clot. If you get COVID, you might get more than that, even if you're young and healthy, even if you're a professional athlete at the highest level. It is somewhat a sign of rich people's problems that America, you have to pay people $1 million lottery, glass of beer, tickets to a ball game for them to take a public health intervention, where in India, where at one point only 1.7, now it's about 4% of people are vaccinated. And you can check this out for yourself, Mark, or your listeners can check this out for themselves. They're underestimating the people who died. They're saying 300, it may be 600, it may be 1 million people who died. And up to 500 doctors have died. So here we have a virus that's basically decimating Brazil, India, some other countries. It's going into Southeast Asia, who did a wonderful job because they have public health mitigation that was at the top of the line. Mitigation meaning everybody was wearing masks. They were staying away from each other, washing their hands. I mean, Southeast Asia was great. And if you include Taiwan, which is the island in East Asia. But now they're getting it because that also means you had a large number of millions of people who had not been exposed because they were so pristine in their mitigation efforts. Now the virus is coming in there and it's saying, oh, yeah, I like these people. They don't have anybody who was sick before. Let's get to work. So we can try to debate whether or not a person can get vaccinated or should get vaccinated. It's their individual personal choice. But I tell you, if we don't do better, I will be surprised if we don't have another spike. It may not be as bad as what we had in January, February, but we're not going to walk away from this virus with 40% being vaccinated.
Absolutely. And what about the idea of long-term either pulmonary or cardiac complications or even renal or other end organ complications as a result of previous infection with COVID?
One of your guys, David Griffin out of New York, leading infectious disease expert, anecdotally, in medicine we use anecdotes when you don't have a real big clinical trial, but it's your clinical suspicion because you see it. And I don't think anecdotes are bad, especially if it's a veteran clinician. He's a veteran clinician out of New York City.